Hey everybody, all you respiratory therapists out there, especially those of you who are in your first semester of respiratory therapy school. And maybe those of you who are in your third or fourth semester and don't remember what happened in the first semester. This video is for you. As the Japanese would say, 𝗕𝗵𝗶𝗀𝗄. Today, we're going to begin a video that's going to be the first part of a series where we examine much more closely arterial blood gases. And today, we're going to evaluate the value of pH. But be sure to like and subscribe and hit the notify button so you're aware when we talk about each one of the values that you might see on the blood gas. And we'll talk about it in detail. Each one, what to think about it, what to do about it, and also what to think about it in terms of the NBRC examination. So let's first talk about pH. All right, this kind of surprises people because people often ask me what to think about pH when I get on the examination or even in real life, and they're always surprised to hear that I say, I actually only think about the pH in 3 specific cases. In other words, I don't look at the pH first. I look at CO2 first because CO2 tells us most about ventilation. So what are the reasons that we want to take a look at the pH when we look at an arterial blood gas? Now, even though it's listed first, often I look at it last, but let me show you why. All right, the first reason that I'll look at pH is to determine if they are COPD. Now remember, we have COPD patients because gradually as they cannot breathe, they cannot exhale their gases, they gradually start to retain carbon dioxide. And it's the carbon dioxide that's the real threat to the patient. It's not the pH by itself. pH is a late manifestation, but what we know is as carbon dioxide goes up, then pH is supposed to go down, and so there is that relationship. So if I look at a blood gas and the first thing I look at is the carbon dioxide and I see that it's elevated, what I'm trying to determine is the patient in an acute situation where they're not breathing, they have an acute respiratory problem, or are they chronically elevated? And to determine that, I can just glance at the pH. What happens with the pH over time with a COPD patient is that it begins to normalize, and that's not normal. We shouldn't have that. In a normal patient like you and I without COPD, if your CO2 rises, then your pH should fall acutely, and you should have respiratory acidosis. But in a COPD patient, if I see that the CO2 is high, I'm going to glance at the pH. If the pH has been normalized, then that's a good assumption that they're COPD. In fact, it's really not about diagnosing the patient by looking at an increased CO2 in combination with a normalized or compensated pH. In fact, we have to look at a lot of other things, but it's true that there are very, very few situations where the pH will normalize over time. And believe me, it takes months for the pH to do this. It'll normalize over time, and that would indicate to us that the patient has a chronic problem. It doesn't diagnose CO2, but what it does diagnose is chronic carbon dioxide retention, which, by the way, is mostly just associated with COPD. So it's a very indirect way of confirming that the patient is likely, very likely, chronic obstructive pulmonary disease. So the first reason I look at pH is because I want to know if they're COPD or not. And if the CO2 is high, but the pH is compensated, then I believe that they are COPD. All right, the second reason I look at the pH is to confirm that they are in ventilatory failure or respiratory failure or not. Notice that I don't look at it to determine if they are. I already probably know, and I know that from looking at the carbon dioxide. Keep in mind that the carbon dioxide is a molecule, as is oxygen, a molecule. But pH is not a molecule. pH is just the outcome of having too much carbon dioxide. And of course, it's the combination of other things like bicarb and other elements that are in the blood that will cause the pH to shift. So pH is not a molecule itself. We're not looking at a pH level. It's a very indirect way to see what's happening with the carbon dioxide and the blood acidity as a result. And so because of that, there's one true thing that we can keep in mind, and that is that there is a fixed relationship between carbon dioxide and pH. In other words, if carbon dioxide goes up by a certain amount, very predictably the pH will go down by a certain amount. It will become acidotic. This is what's because of the respiratory relationship, and we all have that. Now, there are things that can affect that, but for sure, if the CO2 goes up by, say, 10, then the pH is going to go down by 0.10. It's also 10, but it's after the decimal place. So I can look at CO2 by itself, and I can determine if I have respiratory failure. Now, let me go back to the pH for just a minute. The normal pH is 7.35 to 4.5, but we would consider ventilatory or respiratory failure when the pH reaches 7.25. Now, I have to caveat that just for a moment. You may look at different books, and some books will say 7.28, some will say 7.25. I've even seen 7.24. I like to use 7.25. That's probably the most common one, and that's the one that makes me most comfortable and successful on the NBRC examination as well. So your teachers might teach you something different. It doesn't really matter. We're going to use 7.25. Well, if the pH is 7.25, then predictably, remember there's a fixed relationship, then the CO2 would be about 55. So in reality, when I look at CO2 and I find out that it's 55 or higher, I know that the patient is failing to ventilate. Kinda. I want to glance at the pH. If there's COPD and it's compensated, then that isn't ventilatory failure because they're used to a high CO2. But if they're not COPD, then the pH predictably should fall, and once it crosses 55 on the CO2, it should cross the 7.25 or the point at ventilatory failure on the pH. So I look at the pH just to confirm that for this patient, it truly is ventilatory failure. Now, I want to mention something else about ventilatory failure that often surprises everybody. And I'm going to say this straight out. Ventilatory failure, or a pH of 7.25, is not an emergency. But boy, if you're saying that somebody is having ventilatory failure and ventilation is a vital function of life, why isn't that an emergency? And it's because an emergency really is defined as the loss of vital function such that the patient literally is in a few minutes from dying. So they're within a few minutes from death. And that's when we would probably call a code. Well, on the blood pH, if we're going to define ventilatory failure, do you think we would define a number that would bring us all the way to just a few minutes before dying? No. We want a value that's well before that. And so we use a pH of 7.25 to decide they are in ventilatory failure, but it's well before we have to interact with them in an emergency fashion. In other words, we're not going to call a code just because somebody's pH is 7.25. Now, what are we going to do? We are going to intervene from a ventilation point of view. In other words, we're going to start mechanical ventilatory support. We're going to intubate the patient, put him on a ventilator. So it is important when we see a pH of 7.25, but it's not a cause for an emergency. And that means we don't necessarily need to put him on 100% and push the code button and start doing compressions on the patient. No, we don't need to do that, but we do need to intervene very precisely and quickly when we see a pH of 7.25. pH 7.25, not an emergency. This is especially important to remember on the examination. All right, now the third final reason that I look at the pH is a very special case called diabetic ketoacidosis. Remember that we said that when the pH goes down, it must mean that the CO2 is rising because those two things go in opposite directions. So if a CO2 rises, then the pH should go down and become more acidic. But every once in a while, you look at a CO2 and instead of being high, it's excessively low. And it'll be obvious to you because the patient is breathing super fast. In fact, they'll have sometimes a breathing pattern called Kussmaul's breathing. Kussmaul's breathing is when they breathe fast and as deeply as they can. As you might imagine, that's going to blow off a lot of carbon dioxide. So when you look at the CO2, you'll see a carbon dioxide that's very low, very often in the teens. You're not used to seeing carbon dioxide that's 35 to 45, but this will go down into the low 20s or 17 or 16 or 15. It's very alarming to see a carbon dioxide so low. Well, if the carbon dioxide is going that low, then the pH should be going up to extreme alkalosis. You should be seeing alkalosis of 7.70 or higher in that case. But with diabetic ketoacidosis, something opposite happens. Even though the CO2 is low, even in the teens, you look at the pH, should be alkalotic, highly alkalotic, but what you'll see is it's excessively acidotic. And when I mean acidotic, I mean well below 7.25. Sometimes it's 7.10. I've even seen 6.9 before on a patient. The combination of extremely low CO2 but also extremely acidotic pH or a low pH is evidence of diabetic ketoacidosis. Now, what do you do about it? Well, the respiratory system is not something you need to address. The patient's breathing hard and fast because it's trying to make the blood more regular, a little bit normal base, acid-base balance. So it's trying to blow off some of the acidosis that's accumulating, but the acid's coming from the metabolic system. So that's why the patient's breathing so fast. Your main concern with the patient at this point is that they're trying to sustain extreme breathing, fast and deep, and the fact is they might tire out, and then that could actually be life-threatening. So I do look at those combinations of things with a excessively low or acidotic pH, sometimes 6.9, 7.1, 7.0, in combination with a low CO2 to assume they're diabetic ketoacidosis. And there's all kinds of interventions with that that somewhat go beyond the scope of our practice, but it's going to involve in giving bicarb, and it may also involve managing the diabetes itself. So we'll probably use glucose and try to get a normal blood sugar value. All of those other things will help to resolve that. But that's the third reason I look at the pH to see if they are involved in something called diabetic ketoacidosis. Now, there are other reasons and other combinations on the blood gas that are very, very rare and go beyond our scope of practice, something that you may learn in the field, but you don't necessarily need to know while in school or even for the NBRC exam, and that is Tylenol overdose. We'll also have a very specific pH and CO2 combination, but those are the three things that you would probably want to be aware of with regard to the pH as you're in school, as you take care of patients, and as you prepare for your NBRC exams. I hope this has been helpful. Remember to smash the like button if we're on the right track, and also remember to subscribe and hit the notify button if you want to see the other videos that'll be coming out on the other elements of the arterial blood gases. What to think about them, what to do about them, and what to think about them concerning the NBRC examination. I'm Dennis from Respiratory Sensei. We'll see you around.